Hello and welcome to Talking General Practice, the podcast from GPonline. I'm Emma Bower, the editor of GPonline. Today on the podcast, I'm joined by our deputy editor, Nick Bostock, to talk about some of the latest news affecting general practice. And later on, we'll be joined by our senior reporter, Kimberley Hackett. Coming up, Nick and I will be talking about the BMA's vision for how to rebuild general practice in England, what both the BMA and the RCGP want from the new government, and how the BMA's ballot on collective action, which closes on Monday, plays into all of this. We're also talking about what happens next for physicians associates in general practice after the Royal College of GPs called for a halt of recruitment of PAs last month. Later on, Kimberley will be highlighting our good news story this week, which is about a GP who was awarded the contract to run her practice after a 3.5-year battle. That's all to come on this episode of Talking General Practice. So first up, Nick, let's have a look at the BMA's vision for rebuilding general practice in England. I spoke to Tim Gardner from the Health Foundation on the podcast the other week about what a new Labour government could mean for general practice. But since then, we've seen a number of things coming out from both the BMA and the RCGP, which really indicates what GPs want to see from this new government. The main thing from all of this, I suppose, is this new vision for general practice from the BMA GP committee in England that was published at the start of this week. What exactly is this?
This document is really a GP-specific manifesto from the BMA. It's something that the BMA England GP committee has been working on for some time. And I think if the general election had come a bit later in the year, as most people expected, it would have formed a key part of BMA campaigning in the build-up to that election. And as it is, it's become sort of a post-election statement of what the BMA's GP leaders want from the new government. So in terms of what's in it, its official title is Safety, Stability, Hope, a vision to rebuild general practice in England. And those three words, safety, stability and hope, are effectively three overarching themes that the GP committee's packaged its list of demands into. The safety element's basically about funding and the workforce. And those are two major factors in the GP crisis that are very much intertwined. We've talked about the unemployment crisis facing general practice at the moment. The BMA says thousands of qualified GPs are out of work because practices can't afford to recruit. And we've reported on some shocking examples of the situations GPs who can't find work are in. A GP working as an Uber driver, for example, another applying to work for Tesco, and others using food banks because their income has dried up. And the GP committee wants mechanisms rolled out within this financial year to create jobs for GPs and practice nurses, as well as to begin to reverse the erosion of general practice funding, which is now more than £600 million short of where it was when the 5-year contract started in 2019. And next, under the stability heading, the GP committee is calling for a long-term commitment to increase the proportion of NHS funding going to general practice. And it also wants a wider commitment to general practice through something it's calling a 2025 Family Doctor Charter. So that term, Family Doctor Charter, harks back to an important milestone in the development of modern general practice that came in the 1960s. A GP, an academic called Steve Gillam, wrote a few years back in the British Journal of General Practice that the original Family Doctor Charter was an iconic event in the history of general practice that ushered in a sort of golden age. And he noted that one of its key merits was that it targeted new money at the basic building blocks of general practice rather than at what he called mystical quick fixes. So the money went largely on staff, training and premises. And there's perhaps an echo there of what GPs are calling for now, investment targeted at core funding rather than money supposedly for general practice being targeted through PCNs or through the ARRS or even at new models of care, which we know that NHS England has been looking at piloting. The original Family Doctor Charter resulted in a big contract overhaul in 1966 under a Labour government elected with a landslide. So current GP leaders may be hoping there's another echo to come there as well. When it comes to the hope element of the BMA's GP manifesto, that's focused on the prospect of an overhaul of the GP contract within this parliamentary cycle, as well as a commitment to move away from the current unsafe ratio of GPs to patients or patients to GPs. The BMA GP committee says it wants to fix the contract, not the model of general practice. So it says the model is not broken, but that it's been dismantled and underfunded by successive governments. And broadly, the idea is to shift the NHS towards a more proactive, community-focused model basically a plan to rebuild the NHS around the family doctor. And the BMA document talks about transforming the NHS over the next decade into a home first, community second, admission last model to prioritise prevention and build back preventative care through expert generalist GP-led general practice.
It's interesting, isn't it? Those three themes, safety, stability and hope, those three themes are really the things that Dr. Katie Bramall-Stainer, who's the chair of the GP committee in England, she's been talking about those things since she actually took on that role. Those are the things she said she really wanted to deliver for the profession in her role as chair, which she's actually spoken to me about on this podcast before. They're also the things she raised in a letter to Health and Social Care Secretary Wes Streeting in his first week in the job. In fact, a lot of the things that are in that BMA vision document, which you've been describing there, Nick, they were suggestions she made to Streeting in that letter. So how is the GP committee saying we can deliver on those three things in this vision?
Again, under each of these three themes, the BMA set out policy proposals it wants the government to take forward. We know the BMA GP committee leadership has met with the new Health and Social Care Secretary, Wes Streeting. So these ideas are all things they'll be putting to the new government. To tackle the unemployment crisis, the BMA Vision document says the government should set up a practice-level reimbursement scheme to pay for 2-year GP fellowship. So this sounds a bit like a version of the Additional Roles Reimbursement Scheme, the ARRS, but with funding going directly to practices rather than through PCNs. And the idea is to make sure that practices have the funding they need to recruit and retain newly qualified GPs coming into the workforce. At a time when thousands of GPs are struggling to find work, as we mentioned, the BMA has said that registrars who are about to qualify, and there's a whole load about to qualify pretty much as we speak, are really worried that there won't be enough jobs for them or jobs at all for them. So this would help to ensure that doctors coming through GP training are guaranteed or more guaranteed to find jobs available when they qualify. The BMA also wants the new to partnership payment scheme restored. So this is a scheme that was discontinued last year. It offered golden hello payments to encourage GPs to take up partnership roles for the first time. And over the 2 or 3 years it ran for, it actually brought around 3,000 new partners into general practice at a time when numbers of doctors in GP partnership roles generally have been falling. So it helped to sort of balance that trend. The BMA also says practice nurses should be included in the ARRS to help practices recruit to that role. And it also suggests that the huge pot of money currently ring-fenced for the ARRS could be used in part to pay for some of these other ideas, the fellowships and the partnership scheme. New funding is also a big part of the solution the BMA GP committee wants, as well as shifting around some of this existing money. The BMA Vision document calls for a further GP contract uplift on top of the 1.9% imposed by the last government for this financial year. That's something the Doctors and Dentists Pay Review Body is quite likely to recommend imminently. There are also some specific calls to improve GP practice funding for vaccinations, to uplift funding for locum cover when GPs are off sick or on parental leave, and a call for better funding for child and adult safeguarding work.
Some of those payments that you talked about there, particularly the vaccination funding and the locum cover payments for sick and parental leave, they've not been uplifted for years. So, obviously inflation's run rampant in that time and they're still basically the same level they were several years ago. So that's sort of the safety part. But what about the stability and hope? How is the BMA saying we can bring that to general practice?
So to build stability, I mentioned the idea of a new family doctor charter. The BMA sees that as effectively the government setting in stone its commitment to a universal GP-led model based on continuity of care. They want to see continuity of care incentivised, and that's something actually Labour has said it's interested in doing, although there have been some questions about exactly how that might work and whether it's in the best interests of general practice the way that it has been sort of set out previously. Core funding in the GP contract, they also want to see that restored. And on core funding, the BMA says general practice has lost around £660 million in real terms over the course of the 5-year contract that started in 2019. And that funding has dropped overall by more than 50% over the past 15 years. And so the GP committee is calling for a gradual shift in the share of the NHS budget targeted at general practice, obviously an upward shift. This document says it wants the proportion of NHS funding for general practice to rise by 1% year on year towards an eventual proportional funding floor of 15p per NHS pound for primary medical services. So they want to move to a 15% share of the NHS budget going to general practice. And so that's asking for a commitment to roughly double the share of NHS funding targeted at general practice over time. There are also some points about giving general practice a stronger voice in ICBs, protecting patient data better, rolling back some of the damaging impact of the PCN DES on general practice. They talk about the way that that's increased health inequalities. On hope, this is about working with government to deliver what the BMA has called a substantive new contract for general practice, one that would give practices and partnerships the resources to rebuild the continuity-based GP model and to restore the role of practices as gatekeepers that deliver proactive, preventive care that keeps patients out of expensive hospital care. We know that currently there are around 2,300 patients for every fully qualified full-time equivalent GP in England. And the BMA wants the government to target a massive change in that, aiming for 1,000 patients per GP over time. So more than halving the number of patients that there are for each qualified GP in the country. That's obviously a longer term target. That's not something that they're expecting to be delivered within even the next decade or two. The BMA points to a statistic that the NHS Confederation has published previously as well, and that's that every £1 invested in primary medical care results in up to a £14 return in economic growth. So that's making clear that money spent on general practice, on quality general practice, is money well spent. And ultimately, the BMA GP manifesto says if you fix general practice, you fix the NHS. So properly resourcing GPs means hospital activity, referrals, prescribing, investigations, unnecessary interventions and costs will all come down. So ultimately, fingers crossed the new government is listening.
You mentioned earlier there, didn't you, that Dr. Brown-Stainer met with Wes Streeting last week, and I'm sure they were discussing a lot of this in more detail. And, you know, some of those things you were talking about there that are in that document, they do reflect some of the things we've heard Wes Streeting say as well, don't they? He definitely sees primary care as somewhere that could help save money in the longer term. He's talked a lot about the cost of going to A&E versus the cost of being seen in general practice. So they've obviously got that on their radar. And he's talked a lot about shifting resources, which obviously is what the BMA and the RCGP both want, into general practice. But obviously we've seen no detail yet about how any of that would work and what it would actually mean. And that last point you there made about economic growth, he's also talked about that, the importance of making sure people are well so that they can work. And that's why they're very keen on the prevention agenda, because obviously a lot of the plans the government has really hinge on growing the economy. And Wes Streeting says that he sees the NHS having a role in helping to deliver that. So obviously there's quite a lot of common ground there, but I guess it really depends how it all comes together and whether they can agree on anything. But I'm sure one of the other things they would have talked about at that meeting is the BMA ballot on collective action by GPs. So that ballot's still ongoing and it closes on Monday. And I think we're expecting to see the results of that fairly quickly. And as we've talked about on the podcast before, collective action could start almost immediately after that. We actually ran a survey recently which suggests the vast majority of GPs in England do support practices taking collective action. So remember, the ballot's only open to GP partners because collective action is something that the practice as a whole, as a business, will have to take. We asked all GPs in our poll, and 304 GPs, 87% said they supported collective action. Among GP partners only, the proportions are actually broadly similar, with 85% saying they backed collective action. So I think it seems fairly likely we will see a vote in favour of action next week. And I'm sure the new government would really want to avoid it coming to that. It's perhaps also worth mentioning here that the BMA has really stepped up its patient-facing side of this campaign over the past week or so to really try and explain to patients what's happening in general practice. This is its GPs Are On Your Side campaign, and there's a video and all sorts of other resources for practices to display, to explain underfunding and really sort of set out this idea that GPs are just as frustrated as patients with the current situation. Obviously, keeping patients on side and supporting the profession will be crucial if any collective action, or indeed, industrial action eventually, if it comes to that. Nick, NHS England wrote to ICBs this week telling them to prepare for the knock-on impact of collective action. What did that letter say?
So, yeah, I mean, as you mentioned, the ballot on collective action closes on the 29th of July. And if practices vote in favour, the BMA has said action could begin as soon as the 1st of August. So NHS England's letter is just a warning to ICBs to step up preparations for the potential impact of actions practices could take. They want ICBs to be ready in particular for a potential reduction in appointments in general practice and the knock-on impact that could have on other services. The letter says ICBs should be talking to LMCs and to general practice across their area generally to make sure that they've got a good idea of what's coming if collective action goes ahead, because it might not be the case that all practices do exactly the same thing. And then obviously having a good sense of what's coming means you can plan for it. And they're basically worried that hospital services, mental health services, other bits of the health service could come under more pressure if GPs collectively change how they're working as part of any action. We've talked about this before, but the forms of action practices could be asked to consider are not things that would breach their contracts. And that's why this is being described as collective action, not industrial action. So practices aren't going on strike. They're not going to close their doors. But one of the main things practices could do, which our polling shows a lot of support for, and which the BMA has said is the number one thing it wants practices to prepare for, is to implement the BMA's safe working advice. That advice suggests 25 routine consultations per GP per day as the safe limit in general practice. And our surveys and others show that most GPs routinely deliver well over that level of consultations every day. We've got a story that went out this week on that very issue, the number of consultations that GPs are generally doing. If GPs do limit their consultations to that safe limit or something close to it, that could, on the face of it at least, mean quite a significant drop in the number of consultations available. So that's what NHS England is looking at and is worried about. But having said that, the BMA Safe Working Advice also talks about extending consultations to 15 minutes as standard. So that means each appointment gives patients and doctors more time. And the idea is that these longer appointments would improve quality and patient satisfaction and ultimately reduce the need for repeated follow-up appointments. So over time, it might actually reduce demand. There are also ideas in that safe working advice like setting up waiting lists for GP appointments to help prioritise more urgent cases within a reduced headline number of appointments available. So that could also have the potential to push some patients who don't want to wait to go to other parts of the health service. Practices that have already adopted the safe working advice often seem to say that there was an initial bump that was tough, but that ultimately patients and GPs are much happier after a few weeks. So the short-term disruption ultimately leads to positive outcomes, both for GPs and patients. But clearly, if thousands of practices do this at once, it has the potential to create disruption. And that's what NHS England is writing to its ICBs about getting ready for. I think it's probably also fair to say that NHS England might not be wholly convinced that if everyone switches to this safe working model, everything will settle down again within a couple of months. NHS leaders have obviously been focused on delivering the last government's priority, the promise of 50 million more appointments in general practice. And they've often talked up large numbers of appointments in general practice as a good thing, rather than seeing those numbers as something that represents intolerable pressure on general practice. So the idea of shifting to fewer, more efficient appointments, quality over quantity, might be a pretty difficult psychological shift for some people to absorb.
You can also see the headlines, can't you? If those numbers of appointments being delivered overall, it looks like they're falling. You can see how that would be interpreted in certain quarters of the media and the kind of, stick that would be used to criticise the government, NHS England, and GPs themselves. Is there anything that could avert collective action, do you think? What about the DDRB recommendations? We're waiting for those. We think they're due out pretty imminently. There's been a bit of discussion in the media about pay review reports coming possibly, within the next week or so. What do we think that's going to hold?
I think that's a really interesting question. I don't think it's at all clear at this stage how the DDRB advice and what the government decides to do with it will affect the prospect of GPs taking part in collective action. Before the general election, we talked about the fact that we were expecting a report from the DDRB, that's the independent body that advises the government on pay for doctors and dentists, to be sitting in the inbox of whoever became Health and Social Care Secretary after the election. I mean, technically, it might actually have been sitting in the Chancellor's inbox. I'm not quite sure about that. Anyway, in the government's inbox somewhere. It looks like that was the case. We know that reports from pay review bodies across different bits of the public sector are now with the government. So the new Chancellor, Rachel Reeves, has said that she's currently looking at review body advice, not just for doctors and NHS staff, but across other sectors such as teachers and the police, for example. And this year's advice from the DDRB is a bigger deal for general practice than it's been in some recent years. So that's because over the course of the 5-year GP contract that started in 2019 and ran until the end of March this year, recommendations on overall uplifts to the GP contract were not part of the DDRB's remit. And that's because the multi-year contract had these fixed annual uplifts baked into it. So all of that has changed now that the multi-year deal has ended. And this year, the DDRB will make a recommendation on a total uplift to the GP contract, as well as giving advice on how pay should increase for salaried GPs and other staff in general practice, which is something it's been doing throughout the course of that 5-year contract. So Rachel Reeves said last weekend that the government was currently reviewing public sector spending and the public sector finances to inform decisions on public sector pay, and that she expected to announce public sector pay offers this month in July. So obviously that's within the coming days. For general practice, the BMA England GP Committee chair predicted earlier this year that the DDRB might recommend a further 4% uplift on top of the 1.9% that was imposed earlier this year. So that 1.9% uplift, obviously, which was way below inflation, even further short of what the BMA had asked for, was a big part of what triggered the whole collective action ballot process. Reports have suggested in recent days that some review bodies are recommending uplifts of around 5.5% in total, so broadly in line with that BMA prediction potentially. But in the coming days, we'll probably find out for sure what's been recommended and whether the government's decided to accept it. And this might be the first really big test of the Labour sort of honeymoon period. Rachel Reeves hinted strongly that the government will back above inflation pay and funding uplifts for the public sector. So that suggests possibly she's minded to accept the DDRB advice. But let's say general practice is offered a 4% uplift on top of the 1.9% that it's already got, as the BMA's predicted. That's still, as I said, way short of restoring the profession to the level of funding it had at the start of the 5-year contract. The BMA also actually says practice funding has been eroded by more than 50% in real terms over the past 15 years. So an overall uplift of around 6% is also obviously nowhere near reversing that erosion. If the government backs 6%, is that enough to persuade the BMA GP committee to put collective action on hold? Will GP leaders see that as a big enough olive branch to persuade them to stand down? As I said just now, the number one element of collective action the BMA wants practices to take part in is to adopt safe working advice. And there's another factor here that comes into play. The BMA has actually been calling for practices to take those steps for at least 5 or 6 years anyway. So maybe the GP committee will feel practices should press ahead with that, whatever the government offers. But perhaps if the BMA feels collective action could undermine negotiations over a new contract, or if the government awards a sizable uplift and then promises there's more to come in future, maybe they'd consider backing down. So either way, we'll find out shortly. And the next weeks could be pretty momentous for general practice.
Yeah, definitely. And we'll have a close eye on what's coming out of the government on all of this and the BMA's reaction to that. So yeah, do keep an eye on the website for news about that. We've talked a lot there about what the BMA wants to see from the new government in terms of stabilising general practice. But the Royal College of GPs, the RCGP, has also written to the government in recent weeks. And obviously they will be meeting ministers for their own discussions about general practice. Clearly, there's a lot of crossover between what the BMA and the RCGP want. Both of them, as I mentioned earlier, have been talking about increasing the share of funding for general practice for many years now. Well, that will definitely be something the college will also be pushing Wes Streeting and the government to deliver on. But the RCGP's recent letter to Wes Streeting, which it actually asked GPs to also sign, was calling for an overhaul of the targets in the NHS workforce plan around GP numbers. So over 9,500 GPs have actually signed that letter, which calls on the government to urgently review the number of GPs it has in the long-term workforce plan, and which it says the NHS needs. The letter warned that the workforce plan's current aim to increase the number of GPs by 4% by 2036 will not meet the growing needs of patients. And it also highlights, the unemployment crisis that we've talked about on the podcast, and you mentioned earlier, Nick, which has left many GPs struggling to find work despite record demand for appointments. The letter, also points out that 4% in growth in GPs compares with a planned 49% growth in hospital consultants, which just seems a massive mismatch, doesn't it, when you think about it? The RCGP says unless that mismatch is addressed, the workforce plan would, as it puts it, fly in the face of Labour's plans to shift more resources to primary care and community services. We know, as you mentioned, Nick, the BMA really wants to see the number of GPs increase as well. You mentioned there about aiming eventually for one full-time equivalent GP per 1,000 patients, and that will involve a massive increase in the number of GPs we have in England. And that is not what the workforce plan envisages at all. We know from an analysis of that workforce plan by the National Audit Office earlier this year, that analysis warned that GPs were facing substitution by other health professionals. It said the plan intended for, as I mentioned, hospital consultant numbers to rise 12 times faster than GPs, and the NAO warned that the workforce plan envisaged a significant change in how general practice operates, with work typically done by one type of health professional today, i.e. GPs, moved to another type of health professional in the future. That workforce plan is clearly something the RCGP doesn't believe is sustainable or in the best interests of patients or general practice as a whole. The fact this is the first issue the college has raised with the new government, I think, shows that the college's focuses in discussions, I think, will probably really be around the workforce, around growing the number of GPs, and almost certainly as part of that, they will want to see some kind of focus on retention and looking at how we can ensure GPs remain in the job. Clearly, a lot of those issues relate very closely to the issues the BMA is talking about as well. It all links together, addressing underfunding, workload, growing the workforce. And I think that we can expect the new government to be under a lot of pressure from both the BMA and the RCGP about all of these issues in the coming weeks and months. Moving on, we're going to talk about a couple of news stories relating to physicians' associates, one from this week and one from last month. Nick, the first one comes from a poll from Healthwatch about the public's understanding of physicians' associates. What did that poll find?
Polling by the BMA in the past has shown that doctors are really worried that many patients simply don't understand the difference between doctors and physician associates. And this survey from Healthwatch England seems to confirm that concern. Only just over half of patients, 52%, said they understand the difference between a GP and a physician associate. 23% said they didn't understand the difference, and that obviously leaves a big chunk of people who aren't sure either way. Younger people were a bit more likely to say they understood the difference, while among older age groups, less than half said they were clear what the difference was between a doctor and a physician associate. And on the back of these findings, Healthwatch worked with the Patients Association and another group called National Voices to draw up some recommendations. And they came up with 5 key points. I mean, they say PAs, that's physician associates, should explain their role to all patients they see, and that patients should be offered the choice explicitly to request an appointment with a qualified doctor if that's what they prefer. They also said patients should be informed about the differences between types of health professional and the variation in waits to see them. So potentially they could choose to see a PA immediately or wait a bit longer to see a GP. The recommendations also call for clarity about the scope and content of PA training and about how their performance is assessed, as well as for a sort of proactive NHS campaign to explain the role and a formal evaluation to build evidence around the effectiveness of PAs. So on this topic, Emma, one of the other big stories over the past month or so that we've not had time to cover on the podcast yet was the RCGP's consultation of its members about PAs. So what was all that about?
As you say, this happened at the end of last month, but what with the election, we've not really had time to speak about on the podcast. But it's definitely worth some discussion, particularly given that Healthwatch poll you've just mentioned Nick. So as we've spoken about in the past, there's been growing disquiet about the role of physicians associates across the NHS and some real concerns about whether PAs are being used to substitute doctors, both in hospitals and general practice. But, before we get on to talking about this in a bit more detail, I just want to make it clear that none of what we're talking about here is a criticism of any individual physicians associates, but this is rather a discussion about how this role has been conceived and rolled out by policymakers and NHS leaders, really. So last year, the RCGP put out a series of red lines on physicians associates, and earlier this year, at its March council meeting, the college agreed to strengthen those red lines and also consult members of the college on the PA role. And it's quite a big consultation. I'll come on to talk about the results in a minute, but maybe worth reminding people about those red lines. And those red lines, colleges' red lines on PAs, are that when they're in general practice, they must always work under the supervision of a qualified GP. They must never be used as a substitute for a GP. They must be regulated as soon as possible. Public awareness of the role needs to be improved. And obviously that Health Watch poll sort of suggests that that's really important. And training and supervision needs to be properly designed and resourced.
The college's response to the consultation has been pretty strong, hasn't it? What did that have to say?
Yeah, so as I said, it was quite a big consultation. It covered a lot. It was over 5,000 responses they had from GP and GP registrar members. But following on from it, the college has called for an immediate halt on any further recruitment of physicians associates in general practice. So I should say really strong response, because the college says the survey raised some real concerns about patient safety. The college said it showed there was really wide variability in the way PAs are deployed, inducted and supervised. In particular, there were some clear findings that processes around employment of PAs were not as robust as they should be in many places. The college is saying that PCNs and practices should stop recruiting PAs until the role is properly regulated, and practices can implement some forthcoming guidance from the college on supervision and induction and PA scope of practice as well. The college's survey also showed there was quite a big gap between the way PAs are currently working compared to the way GPs and GP registrars believe they should be working. And so I think some of the guidance the college is going to be producing will be aiming to address that gap. In terms of very specific findings, 81% of respondents to that consultation said they thought that the use of PAs in general practice had a negative effect on patient safety. Half of all of the respondents said they were aware of specific examples of patient safety being compromised by the work of PAs. And that figure actually went up to a massive 68% among the respondents who were currently working with PAs. The college, for its part, has said the decision to call for a halt on recruitment had been a really difficult step for it to take, but it said that based on the evidence from the survey, to continue to bring physicians associates into general practice at the minute would not be in the interests of patients, PAs themselves, or GPs who are clinically responsible for them.
What happens now? What's the college doing with the findings of this consultation?
Yeah, so aside from the call to suspend recruitment of PAs, the college also made a series of recommendations that practices should implement now, practices who are working with PAs. It says practices should make sure they're following all of those red lines I mentioned earlier, but they've also added some extra recommendations. They say PAs should not now see undifferentiated patients, which is in line with guidance the BMA produced earlier this year. And the college says that any work PAs do should be delegated to them by their GP supervisor and within a scope of practice for that role agreed for that PA in that practice. College has also said practices need to schedule in appropriate time for supervision into GPs and PAs' daily timetables, and also review their processes for induction and supervision, because as I said, that consultation showed some of that was very, very patchy. Practices also need to make it really clear to patients, much like you said earlier, Nick, who they are seeing when they attend the practice, and that's any member of the multidisciplinary team, not just PAs. And finally, the college says that any patient that sees a PA for a problem, and then if patient represents with the same problem, they need to be booked straight in with a GP, basically. The college also called for governments across the UK to commission urgent reviews into the way PAs are working in the NHS. And it wants increased funding to ensure practices can introduce proper induction, supervision and support systems for staff. And finally, the RCGP wants regulation to proceed as soon as possible. I mean, we know there's a lot of issues around the GMC regulating PAs. The BMA doesn't want that to happen. And the college actually would prefer PAs were not regulated by the GMC as well. But it says that given GMC regulation is so far advanced now, it's basically due to start at the end of this year, the college has said it will continue to work with the GMC to ensure there's clarity over the differences between doctors and PAs.
Do we know what the guidance that the RCGP says it's developing for practices on PAs is likely to cover? And what does it mean for the future of PAs in general practice, do you reckon?
So firstly, I should say, that the college has said that working within the right parameters, physicians' associates have the potential to make a really useful contribution to general practice. The college says the survey showed examples of how the role has actually worked really well. So, let's be clear, the college is not calling for physicians' associates in general practice to be scrapped altogether. What the college's guidance will be looking to do is to set those parameters that it feels physicians' associates can safely work within. On saying that, there were clearly a good number of respondents to that consultation who don't think PAs have a role to play at all in primary care. But anyway, the RCGP guidance, they've said it will cover scope of practice and induction and supervision, and the college is expecting it to be completed in time for its September council meeting, so pretty soon. I think the scope of practice thing will be really crucial because that will set out what PAs should and shouldn't be doing in general practice. We've already had guidance on this from the BMA, but I think the college is the place where people will be looking for some sort of definitive guidance on all of this. The BMA and many others in the medical profession really want the GMC to set the scope of practice for all medical associate professionals, including PAs. And if the GMC does decide to do something like that, it could well look to the Royal Colleges like the RCGP to find that scope of practice for each of the different branches of medicine. So the RCGP scope of practice could have a big impact going forward if something like that happens. We've talked on the podcast before about the fact that the Primary Care Network Directed Enhanced Service, so the contract that networks operate under, we've talked about the fact that that sets out a job description for PAs employed under the Additional Roles Reimbursement Scheme that sees them having a role in seeing undifferentiated patients. And certainly, the NHS Long-Term Workforce Plan, which we talked about a bit earlier, that also implies that that's what physicians' associates will be doing as well. But given what the college has said in the last month or so, it seems very unlikely that will be in its scope of practice. I think in terms of induction and supervision, I'm sure the college will say PAs need to have annual appraisals, proper induction and a training needs analysis every time they start a new role. But it really is quite staggering, isn't it, that we've got to this point where PAs are now being very widely used across the NHS, both in primary and secondary care, without any of these things already being in place. I mean, I mentioned at the start that none of this is the fault of PAs themselves. And I think it must be incredibly difficult for them when they've trained to do a job that they really want to do, maybe at their own expense, and they've undoubtedly worked very hard to get that qualification, and then find themselves working in this environment where there really seems to be very little clarity at a national level about what their role really should be and the support they need. So we've got hope that some of this work the college is doing will sort some of these issues out. Before we go, we've just got time for our good news slot, and our senior reporter, Kimberley Hackett, is going to tell us about that. Hi, Kimberley.
Hello.
So we've talked about this story on the podcast before quite a while ago, and it's about the contract for the Withnell Health Centre in Lancashire. So just remind us, what's the background to that story?
So this all started back in 2021 when one of Withnell's two GP partners left the practice. Then NHS Lancashire and South Cumbria ICB decided it was going to put the practice's contract out to tender, and this meant that Dr. Anne Robinson, the remaining GP, had to bid to keep hold of the practice's contract. But after the first consultation in 2023, Dr. Robinson, who has actually been at the practice for 11 years, lost the contract to SSP Health, and that's an organisation that calls itself the largest provider of primary care GP services in the region. However, NHS bosses were forced to reverse this decision after protests from patients and staff, and the ICB then acknowledged that it should have consulted more people over the decision and decided to instead award Dr. Robinson an interim APMS contract. But then, in March 2024, the ICB announced it would once again put the practice out to tender to find a permanent contract holder.
And we finally found out who won the contract, haven't we? And it's good news, isn't it? Probably should be if it's in this slot of the podcast.
Yeah, definitely good news. So after more than 3 years of campaigning, it was announced in July that Dr. Robinson was finally made the permanent APMS contract holder, and this will kick in from 1st of October. And when I spoke to Dr. Robinson, she told me she was shaking when she took the call from the ICB, and she is understandably very happy with the decision. But the past 3 years haven't been easy for Dr. Robinson, the staff, or even the patients. She told me the whole process has been stressful, with staff worried about their jobs and patients worried about the future of their healthcare. The community really has come together to help Dr. Robinson. Staff and patients have held protests and sent letters of support for Dr. Robinson, and even raised £5,500 for a bid writer to be hired to help with the bidding process. In fact, during the last consultation, patients had campaigned to discourage other potential bidders from entering the procurement process. And indeed, Dr. Robinson was the only person who placed a bid to run Withnail Health Centre. Now, I'm sure Dr. Robinson would want me to give a special shout out to Louise France and Anne Christopher, who both led the patient campaign. And another shout out goes to practice manager Nicola Phillipson, who worked tirelessly on the bid. Everyone's hard work paid off, and Dr. Robinson said the staff would celebrate with a barbecue, and there is even talk of there being a party in the village hall for all the community to enjoy.
Yeah, that's such a great story. It's really good news that the contract went to the right person. I think we'd all agree. Well, that's it for this week. Thanks so much for listening, and thanks to Nick and Kimberley. I'll be back next week when I'm speaking to Dr. Adrian Hayter, who is the Medical Director for Clinical Policy at the Royal College of GPs, about the RCGP's new clinical priority, which is prevention, and the role general practice has to play in prevention. So please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access a host of other resources on our website at GPonline.com.